Yeah, this is an 86-year-old male with lymphoma, high-risk MDS, low-risk MDS, and other abnormalities. So this 86-year-old gentleman today, but his past medical history is remarkable for atherosclerotic cardiovascular disease, with PCI and stents, hypertension, diabetes, hyperlipidemia, nephrolithiasis, not something that we don't see in the typical patient who enters our clinic. The story goes back to 2009. I'm sorry, there is kind of mistake here in this line. He complained on weakness, and the workup revealed gastritis, GI gastritis, as well as colonic polyp. He was 73 at that time. He also had mild pancytopenia at that time, iron deficiency, which we thought was related to the gastritis. We didn't see this patient at that time. He was in another center. 2010, a year later, he complained again on generalized weakness, and he had in physical generalized lymphadenopathy as well as pancytopenia. Bone marrow was done at that time, revealing 3 lineage dysplasia with 15% blasts and translocation complex karyotype. In fact, he also had cervical lymph node biopsy at that time in that hospital, and it was remarkable for diffuse large B-cell lymphoma. So they decided to treat the lymphoma. He had generalized lymphadenopathy, including mediastinum, retroperitoneum, pelvic, and he received at that time 6 cycles of R-CHOP and achieved complete remission. The pancytopenia remained. If you don't want to call it complete remission, that's fine. He did not receive treatment for the MDS at that time. 2 or 3 years later, there was a relapse of the lymphoma. At that time, he was treated with rice plus intrathecal methotrexate and achieved complete remission again. He remained mildly asymptomatic. He had mild asymptomatic and still had some kind of pancytopenia, which then aggravated at that time. But he was not treated for 2 years. In 2014, the hemoglobin really dropped and he became transfusion dependent. He received ESA, which failed. And at that time, we saw him for the first time. He complained of weakness, dysfunction, transfusion dependent, 1-2 units every week. There was no evidence of lymphoma at that time. You can see the blood count, 5.8 hemoglobin, high MCV, leukopenia, thrombocytopenia. And the bone marrow showed 3 linear dysplasia, this time 6% blast, -Y in cytogenetics, and he was defined at that time as high-risk MDS. He was lucky enough to join at that time to the support trial. Some of you may remember that trial. In this trial for high-risk patients, every patient received the azacitidine, and the patients were randomized to receive either L-thrombopag or placebo, and the idea was to prevent the thrombocytopenia. Because he has transient diarrhea, liver dysfunction, and the platelet rose, we assumed that he was on the L-thrombopag arm, which turned to be true later on. After 6 cycles, there was an improvement in the counts. He became transfusion-free. 12 cycles, the support was terminated because of safety concerns, but his platelet count was normal. L-thrombopag obviously was stopped, but because of incomplete CR and very good tolerance, and he also refused to, and we didn't want to continue or to stop, we continued azacitidine, and after cycle 15, completely normal CBC and CR in the bone marrow. But he continued the AZA with reduced dose, with long interval, more and more, 2 months, 3 months. We don't know if we did the right thing, but this is what happened, and the time moves. In 2016, even he had traumatic right femur fracture, but with complete recovery, just to let you know how well he is and he was. In 2021, the ESR rose to 100 and the CBC started to decline. Bone marrow 3 lineage dysplasia, 1% blast, normal cytogenetics, and NGS, no mutation. So he was defined at that time as low-risk MDS, and at that time, AZA was stopped. A year later, bone marrow was looked the same, and here we are today at the end of 2023. He is asymptomatic, physical unremarkable, very high SEDO rate, mild anemia, 11, ANC normal, platelet mild thrombocytopenia, chemistry normal except for the iron, and some kind of abnormal lab site, as you see, IgM, beta-2 microglobulin, maybe inflammation or who knows what, no monoclonal gammopathy, any other disease was excluded, no evidence of lymphoma, slight splenomegaly, bone marrow about the same, but this time he has mutation of the DNM T3A. So here we are, and we have many questions. I don't know if we have time to answer all these questions. What can you say about the co-occurrence of lymphoma in MDS? How common? What's significant? What do you think about so many cycles of azacitidine? When should we stop? Because, at some time I consulted several people and I got all the three answers. Answer number one was, the patient is doing well. Why do you need to give him aza? Question number two, that the patient is in CR. So why? It works. Let's continue. And the third question was, let's do it, but in reduced dose. Maybe because I'm Mittelman, I did something in between, but who knows? We don't know really the answer. What about the lab abnormalities? What's the role of L-thrombopag that he received? And the most important, what should we do now, considering the lab, maybe the inflammatory and the mutation? Who volunteers to start?
I can take the first one. So definitely this patient has hematologic malignancy-prone stem cells. They've already developed a diffuse large B-cell lymphoma and now has MDS, and he definitely warrants a germline workup. You can see this combination in DDX41 and some of the other germline genetics. I think it's very interesting that he tolerated such intensive chemotherapy for the lymphoma despite having MDS without having more significant cytopenias, so that's pretty impressive.
I would like to refer back to Robert Loop, who said, if what you're doing in your patient works, then you should continue doing it. And if what you're doing does not work in your patient, then you stop doing it. He became kind of cytopenic after 36 cycles. I remember Lou Silverman, when AZA was developed, saying that he had a patient who had 150 cycles of azacitidine. And we actually also have one patient at our clinics who has received 154 cycles of azacitidine. It's actually not impossible to actually carry on with azacitidine in patients with MDS. Now, let me become conservative again. I think it's very good to send patients with myelodysplastic syndromes to centers of excellence, coming back to the MDS Foundation and what Steve Neimer has presented. I think it's very important. Look at this case. At the beginning, the patient had 15% of blasts in the bone marrow and aggressive non-Hodgkin's lymphoma. So he had high-risk MDS and diffuse large cell B-cell lymphoma.
Responding to R-CHOP.
Responding to R-CHOP. Who believes that was high-risk MDS and non-Hodgkin's lymphoma? No one, okay? Probably he had non-Hodgkin lymphoma in his bone marrow looking like blasts and, if little bit vacuolated blasts or something, then he looks like, I would like to see the immunophenotyping of these blasts to say that this was really MDS. So he was R-CHOP treated, which is not a treatment of myelodysplastic syndromes, and then he got into complete remission for 7 years, when then he developed low-risk MDS. And then, I think, it's kind of, so once he got to a center of excellence, he was treated wonderfully. Like, we would all agree with that treatment, and it went on. And now I think the patient, remains with a DNMT3A abnormality at the end of the day. He got on a clinical trial, fantastic. He had this response. He has a DNMT3A abnormalities, and I think I tend to agree with what you say. This is this is somebody who has a problem in his bone marrow. He first had diffuse large B-cell lymphoma, now he has MDS. So this is a patient with a problem. But I would stick to Bob Louv's thing, we don't know what to do, so we don't do anything. He's doing fine, so we don't do anything. I would do nothing and just watch him.
Primum non nocere.
So I'm going to take a little bit of a different spin on this and say that I do think that the patient had non-Hodgkin's lymphoma and MDS concurrently. This has been described in the literature. I've seen a few cases of concurrent MDS and lymphoma. Right now we have probably about 20 to 25 patients in our center who have concurrent MDS and myeloma, metachronous. And these are patients who we presume have an early stem cell disease where you have the capacity to differentiate along multiple pathways. And whether they have a germline mutation or not, certainly that is something that we're looking into and may be a contributing factor. The old literature showed that chemotherapy was used for MDS years ago. Eva and Theo ran a study a long time ago using induction chemotherapy for MDS patients where they achieved a CR and then harvested their auto stem cells and reinfused them. But chemotherapy could put patients into remission. The problem was toxicity, age of the patients, and there was nothing that could maintain their remission state. And it was only with the HMAs that we kind of revisited the issue about maintenance. And like you, we have some patients who have been on HMA for a very long time. I have a patient right now on I think 137th cycle of azacitidine. So the question of stopping is an important question, and we don't have an answer to that. So to answer Moshe's question, we don't know when to stop patients. We stopped in our original studies after CR, and all of those patients relapsed. So we switched and continued patients on until progression or relapse of disease, and found that patients who initially had an HI could have a better quality of response with continued therapy and did better. So our pro forma is to continue therapy until the patient is either intolerant or there's relapse or progression of disease. But we don't have a question as to what's the optimal course for use of therapeutic HMAs in these patients.
Okay, thank you, and I suspect that with the interest of time, we'll have to move on. Thank you so much, Dr. Jen Churpek, Lou Silverman, and Ari Giagounidis.